Honorable Vice Principal Sirs, Honorable Chairperson, respected teachers, dear colleagues, and intern doctors, Assalamu alaikum. Welcome to today's weekly seminar on identification and antibiotic susceptibility pattern of pathogenic bacteria isolated from diabetic foot ulcer. With permission of our Honorable Chairperson, I will start my presentation. Introduction. Diabetes affects approximately 9.3% of the global population. A serious and common complication of diabetes is diabetic foot ulcer. These ulcers lead to infections, gangrene, and even lower limb amputations. In Bangladesh, about 44.5% of diabetic patients are at risk of diabetic foot ulcers. These ulcers are highly predisposed to bacterial infections due to reduced immune response and prolonged exposure to moisture creating bacterial growth. Both gram-positive and gram-negative bacteria are frequently present in these ulcers. While these bacteria are resistant to commonly used antibiotics, ulcer healing is delayed, leading to prolonged hospital stays and increased financial burden on patients. Antibiotic resistance rates have been rising alarmingly in low and middle income countries. Choosing appropriate antibiotic is essential for managing diabetic foot ulcers to minimize treatment failure, risk of antimicrobial resistance, and other negative outcomes. This study aimed to identify the bacteria and determine their antibiotic susceptibility patterns isolated from diabetic foot ulcers. Research question. What are the common bacteria found in diabetic foot ulcers and their susceptibility patterns? Objectives. General objective: to identify bacteria from diabetic foot ulcers and assess their antibiotic susceptibility patterns. Specific objectives are: isolate and identify different bacteria by culture and biochemical test. To determine antibiotic susceptibility pattern of isolated bacteria by disk diffusion method. To detect colistin resistance among gram-negative bacteria by MIC method. To detect oxacillin and vancomycin resistance of gram-positive bacteria by MIC method. Materials and methods. This was a cross-sectional observational study conducted at the Department of Microbiology, Dhaka Medical College from January 2024 to December 2024. Partnership sampling technique was used and total 334 samples were collected. Inclusion criteria. Patients who had diabetic foot ulcers attending Dhaka Medical College Hospital irrespective of age and sex. Exclusion criteria. Non-diabetic patients had foot ulcers and patients or legal guardians of the patient who did not give consent. Data collection. Data were collected in a pre-designed data collection sheet. For data analysis, Microsoft Office Excel program was used. Suitable tables and figures presented data. In all statistical analysis, p-value less than 0.05 was considered as statistically significant. Ethical clearance was approved by Research Review Committee of Microbiology Department of Dhaka Medical College. Ethical clearance was granted by the Ethical Review Committee of Dhaka Medical College. Samples collection and identification. Samples were collected by rubbing the deepest area of the ulcer with a sterile cotton swabs and inoculated in blood agar and McConkey agar media. Incubated aerobically at 37 degrees Celsius for 24 hours. Then subcultured on mannitol salt agar, triple sugar iron agar, simon citrate agar, motility indole urea agar, bile esculin azide agar media and incubated at 37 degrees Celsius for 24 hours. Organisms were identified by colony morphology, hemolytic properties, staining characteristics, pigment production, and biochemical tests such as oxidase, coagulase, catalase, sugar fermentation, motility, indole urease, and citrate test as per standard procedure. This photograph shows the identifying feature of Staphylococcus aureus. Staphylococcus aureus on blood agar shows pinhead colonies with beta hemolysis. Mannitol salt agar is a selective media for Staphylococcus aureus. After mannitol fermentation, Staphylococcus aureus become yellow in color. In coagulase test, there is clumping of plasma which indicate coagulase positive. In catalase test, there is bubbling of hydrogen peroxide indicate catalase positive. Enterococcus species on blood agar shows grayish white small colony. There is no hemolysis. Bile-esculin agite positive. Pseudomonas species on blood agar shows large flat irregular colony. And on Medconki agar there is pale colony. On biochemical test it is motile, lactose non-fermenter and citric positive. In oxidase test it is oxidase positive. Acinetobacter species on blood agar shows medium-sized grayish white colony. There is no hemolysis. On Medconki agar there is light pink colony. On gram staining it is coccobacilli. On biochemical test it is non-motile, lactose non-fermenter and citric positive. Klebsiella shows on Medconki agar pink colony, large mucus colony. On biochemical test it is urease positive, lactose fermenter and citric positive, steam test positive. SN E. coli on Medconki agar shows pink colony. On gram staining it is gram negative bacilli. On biochemical test it is motile indole positive, lactose fermenter and citric negative. Protea species on blood agar shows swarming growth. On Medconki agar shows pale colony. On biochemical test it is urease positive, indole positive, hydrogen sulfide producer and citrate positive. Antimicrobial susceptibility testing. The antimicrobial susceptibility test was performed on molar Hinton agar using modified Kirby-Bauer disk diffusion method, and the zone of inhibition are interpreted according to CLSI guideline 2024. MIC was done by agar dilution method. Antibiotic discs are used for gram-positive organisms: ampicillin, azithromycin, erythromycin, clindamycin, ciprofloxacin, doxycycline, gentamicin, linezolid, vancomycin, o-triazoxazole, and teicoplanin are used. For gram-negative organisms, amoxiclav, aztreonam, cefuroxime, amikacin, ceftazidime, cefixime, cefepime, ceftriaxone, ciprofloxacin, o-triazoxazole, gentamicin, meropenem, netilmicin, piperacillin tazobactam, and tigecycline are used. This photograph shows the antibiotic susceptibility pattern of Staphylococcus aureus. Here 3 disc shows that no zone of inhibition. Resistant antibiotics are cefoxitin, azithromycin, and ciprofloxacin. Sensitive antibiotics are vancomycin, teicoplanin, doxycycline, nilezolid, o-triazoxazole. This photograph shows the antibiotic susceptibility pattern of Pseudomonas species. Resistance antibiotics are cefepime, meropenem, aztreonam, amikacin, piperacillin tazobactam, and netilmicin. And sensitive antibiotics are ciprofloxacin, colistin, and ceftazidime. This photograph shows the antibiotic susceptibility pattern of Pseudomonas species. Here 9 antibiotics are resistance. Resistance antibiotics are ceftazidime, colistin, cefepime, meropenem, ciprofloxacin, amikacin, piperacillin tazobactam, netilmicin, and aztreonam. This photograph is the minimum inhibitory concentration of oxacillin of Staphylococcus aureus by agar dilution method. Now coming to the result. Table 1 shows the demographic profile of diabetic foot ulcer patients. Patients are categorized into different age group, gender, and occupation. Majority of the patients belong to 51 to 60 years age group. found in 48.80%. Males are more affected than females, found in 61.08% and 38.92% are female. Majority of the patients are businessmen, found in 33.23%, followed by housewife, found in 32.34%, then unemployed farmers and others. Table 2 shows the distribution of culture results. Among 334 samples, 318 were culture positive and 16 were culture negative. This pie chart shows the culture results. 95.21% were culture positive and 4.79% were culture negative. Table 3 shows the organisms isolated from diabetic foot ulcers. Gram-negative bacteria are more prevalent than gram-positive bacteria. 83.33% are gram-negative bacteria and 16.67% are gram-positive bacteria. Among gram-positive bacteria, Staphylococcus aureus was the most common, found in 11.01%, followed by coagulase-negative Staphylococci and Enterococcus species. Among gram-negative bacteria, Pseudomonas species was the most common, found in 39.94%, followed by Klebsiella species, found in 15.41%, E. coli 14%, Proteus 6%, Enterobacter around 4%, and Acinetobacter around 3%. Table 4 shows the antibiotic susceptibility pattern of isolated Staphylococcus aureus. Over 70% Staphylococcus aureus resistant to azithromycin and ciprofloxacin, only 22 to 25% sensitive to this antibiotic. Around 40% sensitive clindamycin, co-triamoxazole and clarithromycin. Around 65% sensitive to oxacillin, cefoxitin. Around 74% sensitive to doxycycline and gentamicin. Highly sensitive to teicoplanin and vancomycin, 100% sensitive to linezolid. Table 5 shows the antibiotic susceptibility pattern of isolated coagulase-negative Staphylococcus. Coagulase-negative Staphylococcus, over 60% resistant to azithromycin and ciprofloxacin, only 33% sensitive to these antibiotics. Around 50% sensitive to gentamicin, 66% sensitive to co-triamoxazole, clarithromycin, around 75% sensitive to clindamycin and doxycycline, 100% sensitive to oxacillin, teicoplanin, vancomycin and linezolid. Table 6 shows the antibiotic susceptibility pattern of isolated Enterococcus species. Enterococcus species 50 to 66% resistant to ciprofloxacin and doxycycline, 33 to 50% sensitive to these antibiotics, 66% sensitive to ampicillin, 100% sensitive to teicoplanin, vancomycin and linezolid. Azithromycin, co-triamoxazole, clarithromycin, clindamycin, gentamicin and oxacillin are not tested due to they are intrinsically resistant to these antibiotics. Table 7 shows the antibiotic susceptibility pattern of isolated Pseudomonas species. Over 80% Pseudomonas species resistant to ceftazidime and aztreonam. Only 10 to 17% sensitive to these antibiotics. 20 to 33% sensitive to ciprofloxacin, amikacin, cefepime. 44% sensitive to meropenem. 49% sensitive to metilmycin. 52% sensitive to piperacillin and tazobactam, and 89.77% sensitive to colistin. Ceftriaxone, co-triamoxazole, gentamicin, ticagrelor are not tested due to they are intrinsically resistant to this antibiotic. Table 8 shows the antibiotic susceptibility pattern of isolated Acinetobacter species. Over 80% Acinetobacter resistant to ceftazidime, ceftriaxone, ciprofloxacin. 30 to 40% sensitive to amikacin, co-triamoxazole, gentamicin, cefepime, meropenem, piperacillin, tazobactam. 80% sensitive to ticagrelor and 100% sensitive to colistin. Aztreonam was not tested. Table 9 shows the antibiotic susceptibility pattern of isolated Klebsiella species. Over 80% Klebsiella species resistant to second and third generation cephalosporin, ciprofloxacin, aztreonam, amoxicillin, and amikacin. 26 to 34% sensitive to gentamicin, cotrimazole, metilmicin, piperacillin, and tazobactam. 57% sensitive to meropenem, 73% sensitive to tigacycline, 100% sensitive to colistin. Table 10 shows the antibiotic susceptibility pattern of isolated E. coli. E. coli also highly resistant to second and third generation cephalosporin, ciprofloxacin, aztreonam, amoxicillin. 24 to 46% sensitive to amikacin, cotrimazole, piperacillin, tazobactam, gentamicin, and metilmicin. 60% sensitive to meropenem and highly sensitive to tigacycline, around 77%. 100% sensitive to colistin. Table 11 shows the antibiotic susceptibility pattern of isolated protea species. Over 80% protea species resistant to ciprofloxacin and aztreonam. 23 to 38% sensitive to cefixime, amikacin, ceftazidime, ceftriaxone, metilmicin, amoxicillin, cotrimazole, gentamicin, piperacillin, tazobactam. 61% sensitive to meropenem, cefuroxime, colistin, and tigacycline are not tested due to their intrinsically resistant to these antibiotics. Table 12 shows the antibiotic susceptibility pattern of isolated Enterobacter species. Enterobacter over 80% resistant to cefuroxime, ceftazidime, ceftriaxone, ciprofloxacin. 23 to 38% sensitive to cefixime, amikacin, cotrimazole, aztreonam, gentamicin, metilmicin, piperacillin, tazobactam. Highly sensitive to tigacycline and meropenem. 100% sensitive to colistin, amoxicillin are not tested. Discussion. In this study, 95.21% of cases are culture positive and 4.79% are culture negative. These results correspond with Shah et al., who reported that 92% are culture positive and 8% are culture negative. In contrast, Barrel et al. Reported lower culture positivity rate of 80% and 20% are culture negative. This variation is due to differences in sample collection and laboratory protocols, which significantly affect the detection of microorganisms. Gram-negative bacteria are more prevalent than gram-positive bacteria. Commonly isolated gram-negative bacteria, Pseudomonas species, and gram-positive bacteria, Staphylococcus aureus. Liu et al. Also found that Pseudomonas species are predominant among gram-negative bacteria. In contrast, Rahman et al. Reported that E. coli was the most prevalent bacteria. Jahan et al. And Islam et al. Also reported that Staphylococcus aureus was the most common among gram-positive bacteria. In this study, most of the gram-positive bacteria are sensitive to linezolid, followed by vancomycin and picopanine. The oxacillin sensitivity rate was 65.71%, but lower sensitivity to azithromycin and ciprofloxacin. This correlates with the study conducted by Liu et al. And Anwar et al. Reported highly sensitive to vancomycin and linezolid. In contrast, Barrel et al. Showed that 80% are sensitive to vancomycin. Majority of the Enterobacteriaceae are highly sensitive to colistin, followed by tigacycline and meropenem. They are less sensitive to aztreonam, second and third generation cephalosporin, ciprofloxacin, and amoxicillin. Pseudomonas species was sensitive to colistin, followed by piperacillin and tazobactam. Meropenem sensitivity was also notable, only 44.10%. Sensitivity to ciprofloxacin and amikacin was also low, but very low sensitivity was observed to ceftazidime and aztreonam. Previous study by Rahman et al. Also showed lower sensitivity to these antibiotics, and most bacteria sensitive to colistin, followed by meropenem. In contrast, Barrel et al. Reported 62.5% sensitive to colistin. Resistant states vary based on hospital settings and antibiotic misuse. Conclusion. This study highlights that antibiotic resistance is becoming a major problem and a serious concern for the future. Antibiotic susceptibility pattern showed that gram-positive bacteria are sensitive to linezolid, followed by vancomycin and teicoplanin. Holistic was effective against most of the gram-negative bacteria, followed by ticacycline and meropenem. Limitations of this study: anaerobic bacteria of diabetic foot ulcers could not be detected. It was conducted in a single tertiary care hospital, which may not accurately reflect the broader situation across various healthcare settings. Message to carry home: to prevent antibiotic resistance, unnecessary antibiotic use must be reduced and public awareness should be increased. Antibiotic susceptibility test should be done to identify drug-resistant bacteria in diabetic foot ulcers. Diabetic patients should be educated on proper foot hygiene to reduce the risk of foot ulcers and infections. References: thank you all.